So it's my pleasure to introduce the next speaker, Benjamin Katz. Benjamin's the Associate Director of the Emergency Services in Glens Falls Hospital. He did his training at Albany Medical Center. He originally came from Philadelphia but decided that Glens Falls is the place to be. So we're happy to have him here. There's a significant population with DVTs and Ps in this area. And what Dr. Katz is going to talk to us today is about diagnosing the silent killers, what we need to know. Ben.
All right, thank you. So I have nothing interesting to disclose in terms of conflicts. So DVT and P have really always been the bread and butter for emergency medicine, but what I'd like to review are some of the advances in the last few years, and things have really changed quite drastically. We'll talk about signs and symptoms, the diagnostic approach from a ER standpoint, and then touch on management options, although that'll be covered a little bit more in detail later. So if only every case was like this. A young woman comes in with leg swelling, she's pregnant, she just injured her knee, she just drove across country, she's got an inherited clotting disorder, she smokes, and she's obese, and her leg looks like that. It's never that easy. So signs and symptoms, primarily pain, redness, swelling are the things we're looking for in terms of being able to diagnose a DVT. Risk factors were already touched on, but again, so recent surgery or trauma, cancer, inherited clotting disorders, immobilization, hormone therapy, and that can be either oral contraceptives or estrogen replacement postmenopausal. Pregnancy, again, for the same reason, estrogen is implicated, and that increases during pregnancy. Smoking, obesity, and age. The other things we consider: cellulitis, Baker's cyst, which can be a fluid collection behind the knee, lymphedema, venous insufficiency, or superficial clots. So evaluation, duplex ultrasound continues to be the gold standard and has been for quite some time. Occasionally we'll obtain a CT venogram if a patient's being considered for both PE and DVT at the same time. You can run through the legs after doing a contrast load to look at the pulmonary arteries, but we really rely on ultrasound. What's changed here, though, is that that's now in the hands of an emergency physician. So we have ultrasound at the bedside and can actually do the studies ourselves. So this is a normal view of a compression ultrasound. So on the left, you see a vein without compression. On the right, a normal vein is going to collapse. With thrombosis, that becomes non-compressible. So arteries generally do not compress, but a vein with a clot will not compress either. And that's a diagnosis that we quickly made at the bedside in the ER, but many other providers are doing these in their offices now as well. I know some local cardiologists are doing it, and of course the vascular surgeons. So in some ways it's becoming easier to diagnose because the technology is more available. Treatment is changing by leaps and bounds, really, it seems, from year to year, just in the time that I've been in practice. So the old routine was everyone got admitted on a heparin drip, initiate warfarin therapy, and it was a minimum of a 3-day hospital stay waiting for the INR to become therapeutic, and in some people you just could never figure it out, and they were there for over a week. More recently, we've switched to giving injections of low molecular weight heparin and initiating warfarin as an outpatient. Just in the last couple years, there are a number of novel oral anticoagulants, so dabigatran, rivaroxaban, apixaban, that's Pradaxa, Xarelto, and Eliquis, that can just be started with a dose in the ER and they can go right home. Or in patients that are candidates, they can be admitted for a thrombectomy, in which case standard heparin drip is typically initiated. And then regardless of whether they're a thrombectomy candidate or not, generally if they have a very proximal DVT, so if it's nearly in the vena cava, those patients will generally get admitted because they're considered very high risk for developing a PE. And I put this slide up not because I want to give anyone flashbacks to pathophysiology courses, but just again to highlight the changes in therapy. And from the emergency standpoint, the big shift here has been we actually finally have reversal agents for some of the new drugs. So heparin has always been reversible, but more recently there have been advances in terms of reversing warfarin with prothrombin complex concentrate. Last year, a reversal agent for dabigatran was released. That's Praxbind, and the FDA is actually currently fast-tracking a reversal agent for the 10A inhibitors, and we expect to have it available to us next year. And that's particularly germane from the ER standpoint because we're often the ones that have to deal with the bleeding complications, and being able to reverse these drugs is extraordinarily important to us. Transitioning now to PE, so hopefully it's projecting okay, but the arrows are pointing to bilateral emboli in the pulmonary arteries, and this is a cut of a CT angiogram. So signs and symptoms here are going to be painful breathing, shortness of breath, tachycardia with or without arrhythmia, and the most common arrhythmia being atrial fibrillation, hypoxia, hemoptysis. Risk factors are identical to DVT. Differential diagnosis is pretty broad, and on the left are the life-threatening causes, so cardiac ischemia, pericarditis, heart failure, pneumothorax or pneumonia, versus non-life-threatening causes including pleurisy, musculoskeletal pain, anxiety, bronchitis. So how do we differentiate those? Because we don't want everyone to get a CT scan that involves a pretty hefty dose of radiation and potentially can be deleterious, especially in people who come in multiple times to the ER with chest pain. You don't want to give them a CT scan every time they show up. There's several decision rules that have been developed to help decide who needs testing. So while there's other decision rules out there, the most commonly used are PERC and Wells. PERC is really designed as a binary decision. Do they need testing or don't they? Wells helps you risk stratify. So with PERC, if they have any of the criteria listed, if they're over 50, if they're tachycardic, if they're hypoxic, if they have prior history of clot, recent trauma or surgery, hemoptysis, estrogen, or leg swelling, then they are considered to have failed the PERC test, and you then need to employ Wells. If they're negative for any of those factors in PERC, you're done. You don't need to look for PE. Moving on to Wells, this then stratifies you into either low risk, moderate risk, or high risk, depending on how many positive answers are given. And if they're high risk, then you need to pursue full testing. If they're low risk, you can safely not test. The moderate risk is, of course, the challenging one, and that's where using laboratory tests of a D-dimer comes in. So the overall diagnostic approach in terms of testing, electrocardiography, again, because the top 3 life-threatening things on that differential diagnosis include the heart. This EKG shows the classic findings of right heart strain with a S1, Q3, T3, which is very rarely seen. The most common EKG finding is just going to be tachycardia. Chest radiograph, again, helpful for ruling out your pneumonia or pneumothorax. This happens to show the rare finding of what's called a Hampton's hump, which is a pulmonary infarct. So on the patient's right, on your left, on the lower down, you'll see on the periphery of the lung, there's consolidation of the white in the lung field, and that represents lung that has infarcted because of clot. General laboratory evaluation is going to include, basic labs, CBC, metabolic profile, cardiac markers, looking for those other causes. D-dimer is another test, though, that needs to be used with some caution. So going back to the previous slide with the Wells criteria, if you order a D-dimer on every single patient, you're going to wind up being forced into doing many unnecessary CT scans, and that potentially can cause harm. So choosing the right population in which to use that test. For those that don't know, it's a screening test that will be elevated when a clot is present, but can be falsely elevated as well. So if you have an elevated D-dimer, it prompts you to do a CT scan, but if it's negative, it can prevent you from having to pursue further testing. For imaging, CT angiogram has replaced pulmonary angiography as the gold standard. There's still some patients who can't undergo CT, often because of contrast allergies. In that case, VQ scan is an option, as a ventilation perfusion scan. And then echocardiogram is really becoming more and more utilized, especially at the bedside in the ER. Again, this is another thing where we have bedside ultrasound in the ER, and especially in the very, very sick patient, potentially with undifferentiated shock, it's something that can be employed to help make the diagnosis. So this is I don't know if this will play or not. Nope. All right. So my videos aren't playing because I don't have a mouse. But this demonstrates a 4-chamber view of the heart, and this is normal. This is taken from the apex. So in the center of the screen is the left ventricle. Your right ventricle is partially cut off there, and then the atria are at the bottom. And this is just demonstrating what normal looks like. With PE, because there's outflow obstruction of the right side of the heart, the right ventricle enlarges. And in the patient that's too sick to go straight to CT, or you're about to code, this is a great way to decide what's wrong and what's the best intervention. So we don't do echocardiogram to the level of a cardiologist in the ER, but we can make that binary decision. Hey, is that right ventricle the same as or bigger than the left ventricle? And that can help you make the diagnosis without having to study for a year to get your ultrasound registration. Shout out to all you ultrasonographers there. And then occasionally you're lucky enough to actually see the thrombus traveling through the heart, and here you see collapse of the left ventricle with a dilated right ventricle with clot in it. So treatment options, unfractionated heparin drip is still option, low molecular weight heparin, and then again the novel anticoagulants can be used for PE as well. And lytic therapy. The last two being the kind of big changes in the last few years in terms of how frequently those are used. So who to treat? And again, this is in terms of lytic therapy. There's several studies out there showing great benefit to giving TPA to patients that are having a cardiac arrest from known or presumed PE. So it's easy in the patient that's already in the hospital, that's been diagnosed, and then they suffer an arrest. But for the patients that come into the ER undifferentiated, using that ultrasound and seeing those findings can give you the clue to potentially give TPA and save their life. Standard care for quite some time in terms of treating massive PEs where they're hypotensive or hypoxic and clearly really, really sick. Where I think we're going to see a lot of change in the next few years, and there's, again, several studies to this effect, is the submassive PEs, especially if right heart strain is seen on echocardiogram. You can prevent pulmonary hypertension from ever occurring by giving lytics to those patients. Low risk, of course, are not going to need lytic therapy, so those are the subsegmental that are in the branches of the pulmonary artery, or if there's no right heart strain, those patients still generally wind up on anticoagulation. I think the subsegmental PEs are going to be ones that are debated soon in terms of whether those get treated at all if there's no additional clot burden. The last question to address is just who to admit. currently, the standard of care is to admit everyone. So there's a theoretical risk of arrhythmia in patients with PE. Again, this is another thing that I think is going to go the way of the dodo bird, as we realize that echocardiogram can screen patients in terms of who's at risk or not, and if their echocardiogram is reassuring, quite likely they're not going to require admission, especially with treatment options that don't require parenteral medication. But I think that's in the near future, within a couple of years, but not quite ready for prime time.